Today we have a special grand rounds, mainly because I'm a hospitalist, and we're gonna have a hospitalist presentation, a collaborative, between four of my partners, and I will present them in the order they are gonna present. Please, raise your hand for everybody to know you. Dr. Tucker, he's a product of USD. He did his IM residency here, and he's one of the founders of our hospitalist program. Thank you. Dr. Jairus, he's a UNMC graduate, and he's been with Sanford for the past 8 years. He's an associate professor on the clinical track here at USD, and he's also the clerkship director for Pillar 2. Dr. Oliver, he's a hospitalist. He's been with us for the past 5 years. He's also an associate professor at USD, and he's a published author. He authored the cardiology section of MKSAP, so pretty strong publishing there. Thank you. And Dr. Piazza, she's coming from Creighton. She joined us about 4 years ago. She's an assistant professor at USD, and she's involved in several quality projects with us and helping out with several committees really interested in pharmacy and formulary and therapeutics committees. So these are all my colleagues, and I'll invite Dr. Thacker to come and present GI prophylaxis in critically ill patients.
Well, good afternoon, everybody. Thank you, Roxana, for introducing all of us. Most of you guys already know us because you've spent half a day or maybe done your sub-Is with you, and I see some residents and some pharmacy folks. I think our topic here is going to be loved by the pharmacy people, because I'm going to talk about GI prophylaxis in critically ill patient. Again, I want you to understand that this topic is not about GI bleeding. It is about prophylaxis. So as we know, we admit a lot of medical patients and sometimes appropriately and inappropriately use GI prophylaxis. And part of it is because there is no published set guidelines to guide us through this treatment or prophylactic pathway. So I thought this would be an interesting update, as in last year there has been a meta-analysis that was, and then there was also a multi-central trial that was done. So we thought we'll kind of go over that. I have no disclosures. I work for Sanford as a hospitalist, and also I have a faculty appointment with USD, but no financial interests there. So if you look at the epidemiology and pathology of why there is increased risk of ulcer disease in hospitalized patients, you can see that it is usually because of erosions that occur. Typically, that is not overt GI bleeding. However, there is the risk of ulceration, and here are the risks that you can go over. It is because of impaired mucosal protection, poor gut perfusion in people who are sick, septic, and then there is usually hypersecretion, but the only way we have proven that is in trauma patients, particularly the head trauma patients. And then there is some association with H. pylori infection as well. So these people are usually at increased risk because they are in the unit, they are either NPO or on high-risk medication. So we'll go over some risk factors. There are some definite increased risk factors, which include the mechanical ventilation for more than 48 hours, and this has the highest odds ratio. Coagulopathy, which also has an increased risk, but again, as you can see, this is lower on the risk category. And then other risk factors, including shock, sepsis, renal failure, trauma, burns, more than 35%. We don't see that in our practice area here, but those are the increased risk factors. Now, there have been certain arguments I hear from the residents about people who are on corticosteroids should automatically get GI prophylaxis. There's really not any data to support that, but we have other risk factors that are coexistent when these patients are in the ICU. So we do use that, but again, it's not just because it is isolated glucocorticoid use, but it is in coexistent with either they are sepsis, they have respiratory failure, they've been in the ICU, they're in shock, all those things. So if you look at definite risk factors or indicators, there's coagulopathy, platelet count less than 50,000, INR greater than 1.5, or PTT more than 2 times the control. Mechanical ventilation for more than 48 hours. There is a history of GI bleed or ulceration in the past. If it is clearly documented, they have that history. Traumatic brain injury, spinal injury, burns patient. And then minor criteria, they say it is either sepsis, stay in the ICU for more than 7 days, suspected GI bleed, and then glucocorticoid therapy. Again, it is quite high for hydrocortisone daily dose to be in that category, but we use these indicators. What agents should we be choosing in these critically ill patients? Well, it depends on the effectiveness, the cost, the formulary for that hospital, and then considering any harm that they may also cause in these patients. So if you look at effectiveness, I'll go over some to PPI, H2 antacids, and some prostaglandins or prostaglandin inhibitors. But the data clearly suggests that one agent over the other is really not that different. We'll go over some data for that. So as you can see, I don't have to go through the functions or how these medications work. So here's the data. H2 blockers versus PPI. So there was a meta-analysis that was run in 2018 on the Cochrane database, and it showed that PPI use prevented more upper GI bleed events than H2 blockers. So in efficacy, this is better. Now again, this is a compilation of multiple studies, not just single studies. There's also there was concern with PPI in terms of their side effects or harm, potential harm. So in the past, there was concern that nosocomial pneumonia increased, as well as the incidence of C. diff increased. In these meta-analysis, they have not shown to increase these risks. So if we have to choose one agent over the other in terms of H2 versus a PPI, harm should not be a consideration to choose one over the other. Now again, H2 blockers versus antacids, it shows that significantly lower risk of GI bleed, odds ratio of 0.56 to 0.33. Again, not that great of data on this. These are meta-analysis. These are not randomized controlled trials. H2 blocker versus sucralfate, it's the same if you keep going down. The most compelling data is regarding PPI versus placebo. If you look at the 90-day mortality, there was truly no difference between the two. However, there was lower trend towards GI bleed. Again, if you look at this study in particular, which I'm going to go through right here, it's the New England Journal of Medicine in 2018. The study was powered towards looking at mortality, not at the events, major GI events. So a total of about 3,200 patients, 3,300 patients were randomly assigned to receive either a PPI or a placebo. And at 90 days, 31% of patients in the pantoprazole group and 30% in the placebo group had died, which is about 30% of the entire population, or entire study population. The importance was the 21.9% patients assigned to the pantoprazole and 22.6% assigned to the placebo group had one or the other important event, which is GI bleed, occult GI bleed, or need for endoscopy. These are the, so you can see there is a trend towards lower incidence for all those, but clearly not a big difference. 2.5% of patients had important GI bleed versus 4.2 in the placebo group. So this is the only difference that it occurred in those patients. So again, the final recommendation or final conclusion was that who are at risk for GI bleed, again, the patient selection was based on the risk factors that we just went over on the previous slide. This is only critically ill ICU patients, not general. And I'll go through one more slide here. As you can see, that there are really no guidelines from any society that gives us firm data on who should get prophylaxis on the medical floor. This is the first one that we are now coming across with recommendations from, in fact, the last one I saw, surviving sepsis and the trauma, they both have GI prophylaxis guidelines. But again, these are for ICU patients. These are not for general medical floor. So general medical floor does not have any guidelines at all. Again, the recommendations are based on weak evidence, and that's why this is a grade 2B recommendation. So they should be considered for GI prophylaxis based on their risk factors. And as we went over those risk factors, patients who have been on the ventilator for more than 48 hours, they have coagulopathy, they have co-administration of other agents like glucocorticoids. Those are the patients that should get this prophylaxis. And again, there was data that put these patients at further risk for nosocomial pneumonia and the C. diff. Further data right now is not supporting that thought process, and so we do currently recommend in ICU. So the question is, what agent? Well, I think it is, if you look at the cost analysis, it's very clear H2 blockers have a way cheaper cost profile than your PPIs. Whether it's PPI orally through the G tube or IV, they all have the same efficacy. So we should try to get people off IV PPI on oral or parenteral, NG, any feeding tube if at all possible. However, there's really, between the two PPI and the H2, there's no distinction. We can use an H2 also. So people who are NPO, who strictly need some prophylaxis, ventilated patients, for example, we could use an H2 blocker, famotidine being the first choice, ranitidine the second choice. But I think we fall back on using PPI as our first agent rather than falling on an H2 as our first agent. And that's all I have to say.
Escape on here. All right, my turn. Thanks everybody for coming. Do we have any third-year residents here? Oh, Prince. Is that the only one? The only one that's not entirely, all right one. Only one that's not entirely checked out with a few days left in the residency, huh? So, well, thanks for coming, everybody. So my turn with this, I'm going to talk about two things. I'm going to talk about patients with AFib on anticoagulation who now need antiplatelet therapy because of a PCI. And then also touch on some new HIT guidelines that were published in 2018 with some new updates and inclusions there. And so it seems like everybody has AFib now, especially patients, that are hospitalized. AFib, like many of us, drives us crazy in terms of rate control, decisions on anticoagulation. And a lot of these patients are very, very elderly, a lot of medical comorbidities. And so it brings up the question, what do we do with these patients that need not only anticoagulation but also need antiplatelet therapy for a recent stent placement? In the past, a lot of these patients had gotten put on triple therapy, meaning an anticoagulant and usually 2 antiplatelet agents with a fresh stent. And I mean, in our minds, that just sounds like a bad idea. These elderly patients, chronic comorbid conditions, we're putting on 3 different medications that are going to significantly increase their risk of bleeding. But we felt stuck as providers, right? They had strong indications for stroke risk reduction, and of course fresh stents and the dual antiplatelet therapy. And so I think that has prompted a lot of these studies that we've seen come out. I'm going to get further into this Augustus study that was just published in the New England Journal of Medicine. But all these studies kind of looked at little variations in these antiplatelet and anticoagulant regimens, really comparing triple therapies with dual therapies and looking at the outcomes through that. There's been some meta-analysis done on these trials, and I'll get into that a little later in slides. But I wanted to talk more about this Augustus trial published in the New England Journal just in April of 2019. So a pretty fresh study. I think it had an interesting design, had what they called this 2x2 factor design with 4 different groups that patients were randomized to. As you can see, all of them were getting a stent either because of an acute MI or a stage PCI. And so all of them were on the P2Y12 inhibitor. But then what they did is they had 2 sets of dual therapy, 2 sets of triple therapy. So it allowed us to compare not only the types of dual therapy and triple therapy against each other, but also the anticoagulants against each other, with both apixaban and vitamin K antagonist being included in the trial. So what did they look at? So the primary outcome they were looking at within these 4 groups was of course GI bleeding, or relevant, not just GI bleeding, I guess, major or clinically relevant, non-major bleeding. Looked for secondary outcomes, which included death or hospitalization, and composite endpoint of ischemic events. Ischemic events being an ischemic stroke, a stent thrombosis, or an additional MI. There was 4,600 patients enrolled in the study, and the length that they looked at these patients was over a 6-month period. And so what did we get from data? I wanted to describe kind of what they meant by GI bleed. If you go back to those other trials, what they meant by, or not GI bleed, but what they meant by clinically significant bleed could vary from trial to trial, and I think it's important to note what exactly did they mean by that. But here's what they found. So in that first group with the P2Y12 inhibitor, apixaban and placebo, they found an incidence of 7.3% of major clinically relevant bleeding. Of course, as you move down to triple therapy, add aspirin to that regimen, you can see the statistically significant increase in bleeding there at 13.8%. Then you move down to the regimens that included our vitamin K antagonist, again, a 10.9% bleed on the dual therapy, and then you jump up to an 18.7% incidence of bleeding in the triple therapy with that vitamin K antagonist. And so this really isn't new information, right? We knew triple therapy compared to dual therapy, you're going to have a higher risk of bleeding. So it's just kind of confirming, I guess, what some other studies looked at here. But I think the interesting, you compare the apixaban, the dual therapy with apixaban or dual therapy with the vitamin K antagonist. Even there, you're seeing a statistically significant increase in bleeding with these vitamin K antagonists compared to the DOAC there. So some secondary endpoints they looked at in this was death or ischemic events. I really wanted to look at the ischemic events specifically, but they kind of lumped that in with death and ischemic events, and so it was hard to tease out some of that data. I couldn't actually find where they reported out the actual number of ischemic events in some of these groups. But as you can see here, very, very similar numbers to the death or ischemic events in all 4 of these groups. The rate of ischemic events didn't reach significant statistical significance between the groups, although they do mention kind of in passing in the article that more ischemic events did occur in the placebo groups, meaning the patients on dual therapy versus triple therapy. We'll talk about that a little more in a minute as well. So like any trial, none of these trials are perfect. And some of the things that jumped out to others and myself when reading this trial, the patients taking the vitamin K antagonist only spent 59% of the time in the therapeutic range. I guess you can look at that 2 ways, right? You can look at it meaning it's hard to compare 2 drugs head to head when one of them isn't in the therapeutic range like it should be. but I think it also highlights the problems with the vitamin K antagonist, that it's hard to keep these patients in therapeutic range. And if they're not in therapeutic range, they're at risk for ischemic events if they're subtherapeutic, and they're certainly at risk for bleeding events if they're supertherapeutic as well. The trial was actually underpowered for actual coronary events, and that's a common theme amongst all these trials. There just hasn't been enough coronary events within these trials to really come up with kind of a consensus opinion on some of these little nuances. Some patients were actually enrolled in the trial 2 weeks after stent placement, and I think that's a major concern too, because the highest rate of in-stent thrombosis is right away after that stent is placed. And if you're enrolling people into one of these 4 groups 2 weeks later, you're going to miss some of that. And then, of course, some caveats to the patients in the placebo groups having almost twice as many in-stent thrombosis as the patients on triple therapy. And some of the critique on this trial has also been as the numbers increase. I mean, it was a good powered trial with 4,600 patients involved, but when you're talking, the tens of thousands, if not hundreds of thousands of people that this could potentially affect, that trend for ischemic events occurring more frequently in the placebo group could reach statistical significance at some point here, depending on the numbers. So what are the takeaways, not only from this Augustus trial, but the prior trials comparing these dual therapies and triple therapies? I think very clear triple therapy, like the Augustus trial confirmed, that triple therapy is going to give you a higher risk of bleeding than dual therapy. There was a meta-analysis done on these trials prior to the Augustus trial, again showing the increased bleed, but what they claimed as a similar rate of major cardiac events in these trials. I think another important meta-analysis that looked at kind of these scenarios is that when you have a bleed peri-procedurally, it actually increases your 1-year all-cause mortality regardless. Some of it's related to patient non-compliance. They get put on all these meds, they have bleeding events, and then without the physicians knowing, may stop some of these medications, potentially significantly affecting their outcome. Some other things to look at when you're deciding on dual therapy versus triple therapy is actually the patient's coronary anatomy. How complex was their PCI? Did they need multiple stents to take care of the lesions that they had? And so things like this must also be factored into the anticoagulant and antiplatelet decision in these patients. As I touched on before, patients with AFib undergoing PCI are probably better served at this point actually on a direct oral anticoagulant as opposed to a vitamin K antagonist. That was highlighted in some of the data previously, that the incidence of bleeding was statistically lower than patients on dual therapy with that vitamin K antagonist. But long story short, I think we're still left having to risk stratify these patients in a way. What's their ischemic risk? What's their bleeding risk? And then from there, making an educated decision about what to do with these patients in terms of their anticoagulation and antiplatelets. Here are some of the meta-analyses that we used to kind of look at this data, again, prior to the Augustus trial, with some of the same authors, I would say, as well. Any questions on antiplatelets and anticoagulation before I move on to heparin-induced thrombocytopenia? Nick? Did they differentiate between them? Yeah, no, they are, and they kind of lumped a lot of that together, I would say, because if you read, where is this back? I mean, they talk about any relevant non-major bleeding defined as result in hospitalization, medical, surgical intervention, or unsclered clinic visit. I mean, you could have somebody with kind of benign hemorrhoidal bleeding that get put on this therapy that gets lumped into the bleeding category, and so that they didn't graph it or really report that, but I'm sure that the data would be out there somewhere. But yeah, so they kind of lumped them together, I guess. So that's the principle. Yeah. Yeah. Was that a vascular patient or was that a cardiac patient? Yeah. I think in terms of in terms of coronary intervention, I think the cardiologists are going to choose the P2Y12 inhibitor as opposed to the aspirin. I think the aspirin would be the first thing to go if you ask cardiologists. I mean, I think those peripheral stents are a little larger, and so the vascular docs, maybe in combination with the anticoagulant, are going to be more comfortable with that. But I think, yeah, from a cardiac perspective, they're gonna stay on that P2Y12 inhibitor. So, anything else? Platelets. Buddy? All right. So heparin-induced thrombocytopenia, and this is just kind of an update on recent guidelines published by the American Society of Hematology. I think these came out in December of 2018, and not a lot changed except for the inclusion of direct oral anticoagulants in the potential treatment algorithm for HIT. And HIT, we're always thinking about HIT. It's probably not the most common thing, but it should be always on your radar when we have patients on heparin, Lovenox in the hospital. And something that can be fatal if you miss it. And so we think about it all the time, and cases certainly do pop up if you're in the hospital long enough. And so with these guidelines, they included the DOACs in potential therapy, not only for acute treatment of HIT, meaning starting it right away at diagnosis, but also as a potential option for long-term management. Now, the data based on this, as they say in their statement, their conditional recommendation, very low certainty of evidence about the effects, and they really based this on a couple different observational trials that had, I think, maybe 100 patients or so combined with these. In most cases, had rivaroxaban as the DOAC that was used, but these patients, had good outcomes. When put on direct oral anticoagulant and confirmed HIT. There's some basic science behind it too. There's been some studies on what the DOAC's effect on the HIT antibodies is, and basically came to the conclusion that there really is no interaction between those antibodies and the direct oral anticoagulants. And so I think we're going to see this, like the DOACs are being used more and more for a variety of things. I think we'll probably see it used more in this setting as well. It certainly adds a lot of different options for anticoagulation in the patients with heparin-induced thrombocytopenia. We actually had a recent case at Sanford that I thought was interesting and wanted to bring to the lecture today. So this was a young guy, 32-year-old male, presented with massive DVTs and PEs, vascular saw. He underwent thrombolytic therapy, IVC filter placement. He was initiated on heparin, followed by warfarin. Of course, developed drop in his platelets, had a high 4T score, high suspicion for HIT, stopped his heparin, was initiated on a gatroban, and PF4 antibody did come back as strongly positive while we waited. His platelets recovered nicely, waited to initiate warfarin, but once the platelets had recovered, he got put on warfarin, and I think he probably developed a warfarin-induced skin necrosis, and then you're kind of like, oh great, now what, And so in his case, we actually put him on rivaroxaban per the recommendations of our hematologist, and per some follow-up checks I've done on him since discharge, he's doing quite well on that medication. And so just wanted to update everybody on the fact that these were now included in some guideline recommendations for HIT therapy. Questions? All right, thank you.
Okay, got it. Okay. Thanks, Matt. So I'm going to talk about some updates on asthma. Just before I start, I just want to tell, we generally have a tendency to over-treat most of the time. Even though if there is no justification, I think we all feel a bit more comfortable. We think, I have done something, so I'm covered. I don't think there is anything bad going to happen. So let's see if there is any justification for what we do for no reason. Okay. So the goals and objectives are, I'm going to tell about some guidelines about managing asthma, especially in the perspective of antibiotic given, and also to see if we can use new lab tests which can help us to decide when we may use antibiotics. So let's start off with a question. This is something which we'll see, and my talk is mostly for inpatient setup, and this is not for ICU. This is what general ER admission coming to the floor. So let's see this question. So 30-year-old lady with a history of asthma was seen in the ED with a flare-up of asthma. She had dyspnea and chest tightness, some cough, but no phlegm, and there is no nasal drainage. Her blood pressure was fine. She was a bit tachypneic, tachycardic, mildly febrile, and her SATs were pretty low, 80. And exam, she was in distress, and she had signs of bilateral wheeze, but there was no crackles. Labs were unremarkable. Chest X was unremarkable. So how do we manage? So I just wanted to keep the answer in your mind and see what you may do and what you may be comfortable doing. And then we'll come to that at the end. Ready? You're done? Okay. So now let's talk about bronchial asthma. So asthma is one of the commonest chronic lung conditions which we see in this country. We have about 300 million cases worldwide and about 24.6 cases in the US. And that's close to 8% of the population. And if you see the number of ED visits, that's 1.8 million ED visits. And of that, if you see, almost a quarter of them end up as admissions. So that is 440 admissions. That's almost 1 in 4 end up in the hospital. So we tend to see a lot if they are coming here. And it also ends up with about 3,500 deaths too. And as we all know, based upon the severity, we can manage this outpatient versus inpatient. And usually we can go upon the home meds, go upon the rescue inhalers and nebulizers. Then most of the time you also add steroids. Now the big question is, what about antibiotics? And there was a study done in 2006 in the US by Dr. Stefan. We are going to talk about one of his, it showed that almost 49.1% of the patients who were hospitalized for asthma were treated with antibiotics, even though there is no documentation in the chart they have an active infection. So let's see, and looking at the guidelines, they just say there are not many indications where you may need to use antibiotics unless there is a clear-cut pneumonia where it is justified, or if there is sinusitis. And again, this is only, they are not in the ICU because you don't look for all these things. If they're septic, you just, most of the time you start antibiotics, then you come down. The reason being, most of the infections are not bacterial, most of them are viral. So where does these guidelines come from? So this is based on one of the Cochrane reviews, which was done a couple of years back, and also one observational study which was published in January this year, which we are going to talk a bit more detail. The 6 trials did not find any significant benefit from antibiotics, and the most recent study with about 20,000 patients showed that there was no benefit. At the same time, that also increased the length of stay for no reason, and also obviously that costs more. So not only there is no benefit, it costs more to do things which there is no need for. So let's talk about the Cochrane database systemic review. This was published last year in June. This was published from the UK. So the objective was to see, look at the studies that are out there to see if there is any efficacy and safety of antibiotics for asthma exacerbation. So they used the Cochrane trial register to see all the trials registered for airway disease, and they compared, and the selection criteria was comparing antibiotic therapy for asthma exacerbation in adults or even in children against placebo and the usual treatment. So they could find only about 6 trials, and that had only about 681 adults were total of all trials. And their conclusion was there was limited evidence that antibiotics gave at any time made any difference to their symptoms or the peak expiratory flow rate when they're compared to a placebo. So that was the Cochrane. And then comes the biggest trial, which was done and published last year. Sorry, I'll tell about that at the end. So one trial among them I need to talk about is the Azealia trial, which was published in 2016. So Azealia standards for azithromycin against placebo in exacerbated asthma. Again, this was done in the UK and published in JAMA in 2016. So their question was whether azithromycin, when added to standard care, made any difference. So where did that come from? So the same author, Dr. Johnston, who is from the National Institute of Heart and Lung in London, published a study way back in 2006 called as the TELIFAST study. So the TELIFAST study is telithromycin in exacerbation of asthma. Telithromycin is not used nowadays. It was banned in about 2006. That was one of the macrolides. So when they did that study almost 10 years back, they did find there was some benefit in symptoms in the patient's asthma. So they thought, can we try to reproduce that to see if there's any benefit? So they said, anyway, now telithromycin is not there, let's try azithromycin. Why azithromycin? They thought azithromycin, in addition to antibacterial and anti-inflammatory effects, has also some antiviral effects. So they thought, are we trying to take care of some viral component that may trigger, and let's do that. So they had this thought, and then they did the study. The interesting part is it is a randomized, double-blinded, placebo-controlled study. And they thought they're going to have a substantial amount of patients they can use. So they screened about 4,000 patients in 10 centers in the UK. However, when they looked at that, of these 4,000, more than 90% of the patients already had antibiotic before coming to the ER for that admission. That means they have seen their GPs in England, or they have called a pulmonologist, or they have gone to somewhere else. So no matter whether they had an infection or not, they were given antibiotics. So even though they had a huge pool, they could get only about, I think it was 298 patients out of 4,000 they could qualify. So so the intervention was give azithromycin for one group versus placebo, and azithromycin for 500 milligrams for 3 days. So then these patients were followed up as an outpatient on 2 settings. One is day 5 and one is day 10. And then they asked them about their dietary card symptoms. So they asked for about 3 things: whether they had any improvement in their wheeze, whether they had improvement in dyspnea, or if they had any improvement in cough. So these were the 3 factors they asked if that made any difference. So the results, there was no significant difference between azithromycin and placebo at day 10. So then they thought there is no statistically or clinically significant benefit for azithromycin. So no point. But again, this was only 200 patients. It is a small study. Then next comes the biggest study ever done regarding this. This was published in JAMA in January 28. So this was done in US, and this is the same guy who found out that way back in 2006, almost 49% of the patients who came to the US acute care were treated with antibiotics. So they did this study with to see if giving antibiotics made any difference to their outcome. And all the patients who were involved in the steroids were given given antibiotics had steroids as well. So there is no difference adding or holding steroids. These patients had steroids and antibiotics. So this was a retrospective cohort study, almost 20,000 patients hospitalized in 500 centers in the US. And the exposure was antibodies given in the first 2 days, and at least given for 2 days. Again, they did not take in account of patients who were in ICU. So these are like non-ICU patients. And their main outcome was to see if there was any change in their length of stay. And the results were almost a 30% increase in length of stay. And of course, with the length of stay, there is cost more. And when they looked at the other outcomes, the secondary outcomes like improvement in their symptoms or recurrent admissions or recurrent follow-up, there was no statistically significant thing. So their conclusion was giving antibiotics, which is when it is not indicated, causes more cost, higher length of stay, and also unnecessary side effects like antibiotic-induced diarrhea and C. diff. So now there are some gray areas where we may see patients who may come to the ER or may be admitted, and the patient may not have a clear-cut sign of pneumonia, but they may have some signs that may be suggestive of a bacterial infection, but you don't have an objective evidence, and you are on a fence to decide, should I give, should I not? So again, this study will help us to give some idea about using procalcitonin. Again, many times it is overused, but it can be used judiciously at times. So procalcitonin was found in 1993 that it is typically elevated only in bacterial infections. So that's one. And it is not elevated in viral infections or non-bacterial inflammations. It is specific for bacteria. It rises in about 4 hours to 8 hours, and it peaks in about 12 to 18 hours. And then day 2 to day 4 it comes down. And so this was a trial done in China in 2013. It was a randomized control trial. It was done in a single center, and they tried to see if checking procalcitonin helped you to make decisions about giving antibiotics, and did that make any difference to the outcome. So they randomized about 293 patients. So one was procalcitonin group, one was non-procalcitonin, the control group. So in the control group, the attending physician had no idea what the procalcitonin was, and he made the decision about giving antibiotics based on his clinical judgment. Whereas on the procalcitonin group, they checked the procalcitonin, and half of the patients attendings came to know that the procalcitonin is high, half of them did not know. So before the study was started, they assumed that at least 75% of the patients who were on the control arm are going to have antibiotics, and they were dead right. 75% of the patients were given antibiotics. On the other hand, only 45% of the patients who had the procalcitonin were given antibiotic. So there was a 30% difference. And when they looked at the secondary outcomes, there was no increase in rehospitalization, no increase in length of stay. So I think in some instances, we can use the procalcitonin and make a decision without compromising on the quality. I think I'm running out of time. And so coming back to the question, so based upon this, I think since the patient does not have any evidence of pneumonia objectively, and she does not have any evidence of sinusitis, of course, we don't have procalcitonin. And I think the first one is the best answer, okay? And so two things to take home. One is give antibiotics only if you suspect there is pneumonia or there is bacterial sinusitis, which can worsen. Number two, you can use procalcitonin levels based upon your clinical judgment. Thank you. Any questions?
Did they say what like the serum level of?
Yeah, so if it is less than 0.1, they recommend no. Between 0.1 to 0.25, maybe. If it is more than 0.25, they say yes, go ahead and treat. Okay. By the way, that's not me, that's my son.
So as you can see, antibiotic durations are really changing. We're starting to do things very differently because, you don't want to set off a forest fire in somebody's gut and wipe all the good stuff out. So a lot of research has been going into what to do with bacteremia patients as well as far as their antibiotic durations. And so we're going to talk about kind of some of the changes for antibiotics for Enterobacter ricinae. So anytime somebody has, in the hospital especially, a gram-negative bacilli bacteremia, on initial hospitalization, you have to consider whether they have Pseudomonas or ESBL in the past. That's really going to guide what you do, or if they're high risk for these. So due to rising resistance, a lot of these patients are going to be started on a broad spectrum antibiotic like cefepime or piperacillin tazobactam. But after organism identification, of course, you want to tailor as quickly as you can to what they actually have and need. If somebody is septic or does have that resistance risk, you're going to cover Pseudomonas. And the reason I include this is because often I get these calls at night, and it's not, oh, this patient has Enterobacter. It's that I hear that this patient is going to have gram-negative bacilli, okay? So I don't know that they have Enterobacter to start usually. Carbapenems we do not typically use. If you don't know that somebody has ESBL, don't start with a carbapenem. If you really think that somebody needs a carbapenem, you should consult with your ID specialist if they don't have known ESBL. Okay, we want to protect these antibiotics from resistance as much as possible. And so often your treatment, of course, is guided by which system is involved, where you can get good penetration of your antibiotics to that system. So cardiac infections with Enterobacter ricinae are thankfully quite rare, and these are a beta-lactam plus usually a fluoroquinolone, occasionally an aminoglycoside, and that's usually for 6 weeks, kind of standard endocarditis treatment. CNS infections is often a cephalosporin due to the penetration that you get, and often that's most commonly going to be cefepime based on most review literature. Lungs, thankfully, can be treated with a respiratory fluoroquinolone, and then UTIs are going to be a urinary fluoroquinolone, possibly cephalosporin. Thankfully, in our area, we have a pretty good sensitivity still to cephalosporins, and so a lot of times people are being started for these infections on the standard ceftriaxone based on whatever their infection process is. Okay. As far as duration, which is really our focus, this is what's really changed recently, is we're finding more and more that these shorter durations are adequate to prevent reinfection, relapse, and patients recover. However, anytime you can use less medication, you have less side effects. And so the main takeaway point here is that for a simple bacteremia in which the patient recovers quickly, especially that 24 to 48 hour, they defervesce, they're feeling better, they're clinically improved, they usually will be fine with only 7 days of treatment. You don't need to do these longer 10 to 14 courses generally. And you can often switch these patients to oral medications. Typically, we're using fluoroquinolones here in my experience with patients here. Our susceptibility profiles have been fairly good. Where you may need to get that extended course is in somebody who you don't have control of their source of infection. So, for example, they have a central line or you're looking for abscess. Basically, these people didn't get better right away. And there's something driving this. This infection's hiding either in an abscess or they have persistently positive for fevers and things. And in those cases, you would repeat blood cultures. It turns out also in our simple Enterobacter ricinae bacteremia patients, you do not need to do repeat blood cultures as well. And so if the patient is recovering, you basically can take a much simpler, shorter course of treatment and do 7 days of oral therapy. And then, of course, based on their infection site, they may need a longer course of therapy, and you will usually get your infectious disease specialist to assist you with that sort of determination as a hospitalist. So, and I think we're out of time as well. Does anyone have any questions about that? It's been pretty straightforward. I think most of the newer data came out towards the middle to end of 2017 that these shorter courses were adequate for gram negatives, thankfully. So, yes, ma'am. Certainly. Yes, Enterobacter. Genus, yes, ma'am. Yes. Mm-hmm. Right. Some category, yeah, different category. Yeah, yeah, the new data, 7 days. Yeah. 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 I think that's the case with actually a lot of other bacteria besides Staph aureus, it turns out. I think we've had that about strep pneumoniae and different other. Yeah. Sure. Or maybe you need to explore what the actual source is, like, because you don't have source control, and that's probably where you need to focus your efforts. If they have like an abscess or pyelonephritis has developed, or very, very, very rarely endocarditis, those are the things you probably need to consider. Or do they have a long standing catheter, either IV or urinary? All right, thank you.